And good afternoon, everyone. Welcome to this very special live broadcast event, Inside Medicine, presented by Banner Health. Today, we're having an important discussion around metabolic syndrome. I'm Eric Sperling. I'll be your host and moderator today. We have some of the top minds in the field joining us this afternoon to discuss the important topic from Banner Health. Dr. Imad Khalid, a cardiovascular physician, and Dr. Christine Lovato is back with us. She is a bariatric surgeon. Excited to have both of them live in studio with us, and we look forward to chatting with them in just a moment. But first, some quick housekeeping items because this is a live streaming event. If the stream goes down at any time or you're having connection issues, we recommend just logging off and logging back on. This event will be available to stream and share on demand once the show is over. Very important there. Here's what we're going to do. We're going to be bringing our doctors up one at a time to go over some key items related to this issue and the patient journey. Then we'll have a panel discussion with both of our doctors up on the stage. So we invite you watching at home to submit questions throughout the show using that chat feature on the side of your screen, and we'll try to get to as many of those questions as we can. All right, for now, it is time to meet our first doctor.
I'm Dr. Imad Khalid. I'm a cardiologist at Banner Health. The name of the game is prevention. As you do know, we are our family history. 50% of this whole equation is what you were given when you were born. We want to change the other 50%. So you try to concentrate on the risk factors. But at the same time, every patient is different, and therefore taking a different approach every time you see someone different is important. I like to make sure the patient understands that I'm looking for their best interest all the time. And I want them to feel that they can trust what they heard, no matter how late, no cutting corners, taking the time for each patient.
Very well said. And then joining us live on stage now is Dr. Khalid. Thanks for being here.
Thanks, Eric, for having me.
Okay, we were talking before the show, and we could spend hours talking about the science of metabolic syndrome and everything, every little detail, but give us sort of a high-level definition of what metabolic syndrome is.
Simply stated, this is central obesity, okay? That's when you have a big belly. You're walking the street with a big belly. And that is defined as a precursor to diabetes, cardiovascular disease, stroke, and all the bad players, okay? So if you want to define it as a purist, you have to meet two of the following three criteria. Okay. Number one, in a man, at the level of the belly button, the belt size over 40 inches, and a woman over 35 inches, so a pear size appearance. And number two, your sugar isn't correct, your glycemic index isn't perfect, you know. We measure that by looking at what we call the glycated hemoglobin, meaning your A1C level. A 6.4 equal diabetes, below 5.7, you're considered okay, normal. In between 5.7 to 6.4, you're in the pre-diabetes, okay? That's the second criteria. Okay. The last and third criteria, your triglyceride. Okay. Triglycerides are found in butter, cookies, cakes, bread, pasta, all the good ones. And if normally it should be below 150, if you're above 150, 200, you're in the metabolic syndrome range. If you meet two of these three criteria, you're heading towards a vascular event. You have the metabolic syndrome.
Okay, so you just said in that video too that every patient is different.
Yep.
So how does someone determine then whether they should be a patient or should come to see someone like yourself?
Well, I mean, we encourage risk factors modification. We encourage exercise. We want you to have a screening test, right? Just to know what it is. So we are our family history. So if you're coming from bad family history, everyone had stroke, heart attacks below the age of 65, you better get checked early on. We need a screening lab test. We need to know what's your triglyceride, what's your LDL, what's your bad cholesterol, what's your good cholesterol. What's your sugar level? Do you exercise? Do you walk a good 30 to 45 minutes every day? Where are you? I mean, these risk factors will play a big role, and people should be checked at an earlier age. The earlier, the better.
Because like other things we've talked about here on the show, diagnosing it early is so important. Correct?
Absolutely. The earlier you find it, it's an inflammatory process. You know, obesity is an inflammatory process. Like you have a pneumonia, it's a disease process. Obesity is an inflammatory process. you have a lot of adipose tissue, you have a lot of like visceral fat that's building up in the wrong place, and that will increase your risk factors eventually to develop cardiovascular disease.
Okay, so we've done a good job of defining it. Now we're going to talk about certain treatment options,
Yeah.
and for that, let's meet our next doctor.
My name is Christine Lovato, and I'm a bariatric surgeon. The reason that I chose bariatric surgery as my field of medicine is really because of what I went through with my mom. She struggled with obesity and type 2 diabetes her whole life, and I think that if at some point along the way someone had really offered her an option that could help her take control of her disease, that she might still be here with me today. I would hope that my patients walk away from their time with me and our program with a sense of pride, a sense of accomplishment, an ability to take control of their life and the diseases that have plagued them for so many years, so that they can go on to live wonderful, happy lives.
All right, so good to have Dr. Lovato back on stage with us. Welcome back.
Thank you so much. Very excited to be back.
Okay, Dr. Khalid just talked a little bit about what metabolic syndrome is at a high level, some of the things that help us determine who a patient is. Let's start talking about the treatments now. Surgery, we've got other options. Tell us about some of the treatments once a patient is diagnosed.
Sure. So I think the important thing to remember really is that not everybody with metabolic syndrome has obesity. And conversely, not everybody with obesity has metabolic syndrome. But it's really important to recognize either disease as being present, and there's a lot of options that are very, very similar in treating both of those diseases. So, you know, we've seen a rise of medications to treat obesity. Everybody calls them weight loss medications. I cringe when I hear that because we've established obesity and metabolic syndrome as an actual disease. Now, for the first time in history, we have medications that are created based in science, what a concept, to treat those things. And they're very difficult to obtain still, a lot of cost issues, a lot of insurance coverage issues that we are all working on behind the scenes, but certainly is a really, really good option for a lot of people. For those patients who have metabolic syndrome and obesity, it's definitely, you know, a good idea to talk to your provider about the possibility of medication or surgery. You know, we've established bariatric surgery as a very safe, very effective, long-lasting treatment for both. You know, sometimes we need a little help. As Dr. Khalid said, you know, this is a majority of the risk for developing these diseases comes from the genetic and epigenetic risk that we're born with that we can't do anything about, right? And then 20 million things happen to us throughout our lifetime that will mean that that particular phenotype is going to come to into being, and you're stuck with this disease that could potentially shorten your life, shorten your quality of your life, and we have options to treat that.
So what are some of those conversations like with patients for the first time when you're discussing those options? Because you're right, there is so much information out there right now about the medications, the surgery. What are those conversations like?
So I have tissue in my clinic that's readily available for patients because they have gone through their entire life being seen by other providers and physicians and surgeons being told that they're fat. And we don't use those words in our program. I explain the physiology of their disease to them, metabolic syndrome, obesity, and we remind them that they have this disease that is chronic, that is treatable, and that it's a safe space for them to be able to be open with us and tell us the truth about their daily habits without judgment. And so a lot of them will relax their shoulders and finally, for the first time in history, feel they could actually talk to a doctor about their disease without being judged, without being stigmatized. So that's the very, very first step, which is probably why my clinic visits go way too long.
I'm going to pause you because I want to ask you about that, because
Sure.
you and I have had this discussion before. The stigma seems to be one of your biggest barriers and one of the most important things that you like to talk about in these situations when you have an opportunity to educate patients, educate families. Why is that?
You know, a lot of what I experienced with my mom, you know, everybody who's watching now has seen the video, was stigma. You know, we spent a lot of time cleaning out her pantry and trying to stay away from carbohydrates and going for walks in the evenings. And my mom had severe obesity and very severe metabolic disease. And passed before she turned 60 despite all of the things that we did that the doctors told us to do. And at the time I was a medical student, I was just now learning, you know, the physiology of how the body works, and I didn't understand. But I saw that stigma day to day, every single physician visit that she went to. And it's frustrating now because I can't do anything about it, but it's definitely something that drives my passion for this, for my patients.
Well, you are doing something about it now for others, and let's talk about more, you know, those patient education conversations you have, medicine versus surgery. How do you help kind of determine what's best for? And as Dr. Collins said, everybody's different, obviously. So how do you steer them or have that conversation?
So there's a lot of other conditions that might be present that would steer us one way or another. Certainly if somebody has severe metabolic burden, you know, certain surgeries like a gastric bypass or a duodenal switch surgery would be a much better option for them, much more powerful metabolic change that would occur in their GI tract. You know, a lot of patients come in really wanting the sleeve gastrectomy because they've heard, you know, they've seen it on TikTok, or they've heard a lot of things about it, or they have friends or family who had it. We're learning it's not as powerful. And so certainly patient preference has a lot to do with that. And we have some patients who come in who just want treatment, you know, from a medical standpoint. And we always start where they want to. And just the goal is to educate them so they can make informed decisions about their care.
Yeah, you guys are dealing with stuff you haven't dealt with before, a TikTok generation, a generation of people who are seeing things on social media. You know, Google was around for, you know, much longer, but now you guys are seeing social trends creep up and they're coming into your patient conversations. I do want to remind the audience that there's an opportunity to submit questions. This is the exciting part of this show where we bring both doctors into the conversation. We try to get to your questions live. We do have a bunch of pre-submitted questions that have already come in that what I'm going to do is I'm just going to throw them out there. I'm going to let both of you guys just kind of determine who wants to answer that question. You can both answer them. You can defer questions, but I'm going to start with this one here. Are there early warning signs I would notice, or is metabolic syndrome usually something you only find through the blood test that you guys talked about?
Well, I mean, your body mass index, that's the first sign, the first telltale sign. You know, as I say, no pain, no gain, okay? I mean, if you're coming, and again, we're on the side of the patient, right? We want them to feel comfortable. But the first telltale sign, they're more fatigued, they have less exercise capacity, they're having central obesity, they have to change their clothes and all of that. And, you know, they will present with bad numbers, bad labs initially. I mean, people should get a basic metabolic syndrome, a basic metabolic lab, if you want, a CMP or a lipid panel to see where you are.
Okay.
And I want to tell you, like, if you have a really bad, strong family history of cardiovascular disease, you should have at an early age what we call a screening coronary calcium score. This test is very cheap.
What was it called?
Coronary calcium score. It's a cheap test. It's $90. It's covered by most insurance. Your primary care can order it. You want to really have a big zero. That's the best zero you're going to have on an exam, okay, on that test. And if your calcium coronary score is very high, you better start looking elsewhere. Check what your lipids are doing, what's your triglyceride, what's your HDL, what did they give you, what kind of hand they dealt you when you were born, what's your A1C. It all comes together.
Family history he brought up, seems like we've said it a couple of times already, so important, right?
Absolutely.
And that indicates maybe it's something I should go talk to a physician about?
Absolutely. There's a reason we get family history when we're speaking
Absolutely.
with patients for the first time, because we want to know if you've had a family member that's, you know, a mom, a dad, a brother or a sister, or a sibling or a child even, who's had cardiac disease or stroke or any other metabolic sequelae at an early age. We need to know that, because that just means your risk is so much higher. And so it's really, really important to take that into consideration, you know, and it's important to consider your own health too. You know, a lot of people never struggled with any of those things throughout their life, and we reach our 30s and 40s and realize we've never seen a primary care physician, but hey, maybe we gained 25, 30 pounds as we got a little older, got a desk job, or other things changed in our life. And so, you know, just remaining cognizant and finding a provider that's a primary care provider that you can trust. to be able to talk to about these things, and the options for specialists to go to for treatment is important.
I think you're locked into our live audience because some of the questions are coming in right now, and I'm reading them cold, so I think one of them has to do with primary care. Do I need a referral from my primary care physician to see a metabolic specialist?
It's very dependent on your insurance, unfortunately. Okay. I hate having to give that answer, really.
In general, yes.
Yes,
okay.
but yes.
Again, thank you guys so much, the live audience. Please feel free to submit any of those questions. We've got a great team from Banner Health behind the scenes, Sarah and Sierra here. They will be looking through those questions and getting those to us as they come in. But again, we do have a lot of pre-submitted questions that I do want to get to. Okay, if my blood sugar is high, how do I know whether it's just part of metabolic syndrome or if I'm developing prediabetes or diabetes?
Get an A1C. Go get a hemoglobin A1C and get a basic metabolic test, BMP or CMP, to see what your fasting blood sugar is.
Okay, so this is different from the coronary test you were talking about.
Absolutely.
Okay.
So, you know, the lifespan of red blood cells between 90 to 120 days, roughly 3 months, what have you. If your blood sugar has been day to day abnormal, okay, the average, it tags itself to the hemoglobin moiety of a red blood cell called hemoglobin, and we call it glycated hemoglobin. That gives us the average of your glycemic index on and off, day after day, for the lifespan of those red blood cells, typically, say 90 days. If your hemoglobin A1C is starting to climb above 5.7, and you're in that gray zone between 5.7 to 6.4, do something early. That's the window. That is the window to flip it.
Okay. So
that's the answer.
Absolutely agree. And, you know, and it's important to recognize any other risk factors that you might have that would define metabolic syndrome for you. You know, that includes waist, we already discussed, you know, waist circumference, LDL, triglycerides, high blood pressure can also fall into that category. So it's important to make sure that you're talking to your provider about all of those things and making sure that you're actively doing something, whether it's lifestyle changes, whether it's medication, whether it's surgery, to work towards improving those numbers.
So if I'm hearing this correctly, and forgive me, there are different blood tests for different symptoms. There's not this one catch-all blood test.
True, and I think it's important to remember that metabolic syndrome in and of itself doesn't necessarily have symptoms, right? And that's the struggle. That's the struggle we have. You may not know that your LDL is, you know, above 200. You may not know that your triglycerides are in the 400s. You have to get that checked before they start to affect your cardiovascular health, and you end up, you know, with an episode at some point later in life.
Like Dr. Lovato just mentioned, it's really an epidemic. Really, typically, to be conservative, 15 to 20% of the population has it in this country. And some folks are walking the streets unaware they have it, but there are some telltale signs. You know, you're gaining weight, you're having central obesity, you have numbers that are not kosher. I mean, all of these things that bring you to the attention of your primary care physician, and that's where the screening comes. And, you know, the problem with this is that it's a precursor to what we call the deadly quartets. It's like the quartets, all four of them. Diabetes, heart disease, high blood pressure, dyslipidemia. All of them, they can start acting up one after the other. And if you don't start treating the root of the problem, the inflammatory process in the vasculature and in the cardiovascular system, that can lead eventually to frank diabetes, that can lead to stroke, vascular disease, peripheral arterial disease, PAD, blocked arteries in the leg, in the carotids, in the arteries. I mean, if you do angiograms like cardiac cath over 20 years that I've done, tons, you can tell, diabetic, non-diabetic, diabetic, non-diabetic. So the precursor for all of that is the metabolic syndrome.
Okay. Dr. Lovato, I want to ask you something that you said, and I'm curious because I'm sure this can affect patients of all ages, but you mentioned maybe someone who was an athlete in high school and then was pretty active in their 20s and then never seen a doctor and have always sort of prided themselves on their health, and then all of a sudden they're starting to notice some things and they just refuse to get it checked because they've lived a healthy lifestyle
Correct.
their entire lives.
Correct.
Is that what you see a lot?
We see that very commonly, when we start to get into our late 30s and 40s, research has shown us there's a rapid senescence that occurs at that time. And that rapid senescence, meaning getting older a little bit faster during that time period, means excess visceral adiposity or excess fat around the midsection. And that is the very metabolically active fat that is releasing inflammatory proteins into the body, and that significantly increases the risk of metabolic syndrome. Especially true for perimenopausal women.
And to Dr. Lovato's point, increasing insulin resistance. So you have the insulin just not working to get the sugar into the cell to be used as food, if you want, for the cell life. And with that happening, the beginning of insulin resistance is a slippery slope.
And I want to make sure we hear what you said is very important for perimenopausal
for perimenopausal women. So that extra 5 to 10 pounds of belly fat that we always hear our patients talk about when they got into their 40s and their 50s, no matter what I do, I exercise, I counted my macros, I cut down on my caloric intake, I did all of the things that I know I'm supposed to do that have always worked for me. But we're fighting a metabolic burden that is different from when we were in our 20s and 30s. And that is why the risk of cardiovascular disease in women around that age period is so bad and so scary, because they also have different symptoms when they do present with a cardiovascular complication like a heart attack or a stroke.
We do have more questions coming in. Again, I want to thank everybody for these questions. These are great. What an opportunity to have these two physicians on stage with us. Okay, let's start. You guys have talked about inflammation before. So how do you reduce inflammation?
Well, you treat the root cause that's causing inflammation. So one of the tests that we do, as I mentioned earlier in my talk, that central obesity is an inflammatory process. The metabolic syndrome means your vasculature is inflamed, your arteries are not smooth like they should be, and there is the buildup, the beginning of buildup of microscopic plaque that, believe it or not, if you have that predisposition genetically, start at the age of 15 to 18, and every decade, every 10 years, it gets worse, It builds up more. So folks are fully silent, they're building up plaque in the arteries, they present suddenly with a vascular event, whether an MI, a heart attack, or a stroke, or what have you, because of that ongoing inflammatory process. A simple blood test can tell high sensitivity C-reactive protein. There are other markers of inflammation that we can check, will tell us what's going on with you when we do a lipid profile. Although it is not specific for the arteries, it is very, very sensitive. So anything, any inflammation can be picked up if it's going on. So if you have very high triglyceride, high cholesterol, an A1C that's not right, and you're not doing your thing, you're not going to the gym, you're not watching your diet, and you have a high CRP, there's a problem.
I'm going to ask another question related to blood tests because I heard another one. Let's say I'm in my mid-40s and I want to get tested. Do I just come? It's give me everything? Test me? Give me all of those tests?
It depends.
Or do you guys?
I'll let Dr. Lovato take this one.
I mean, I think our wonderful primary care physician colleagues would be very upset with me if I said yes to that. I think it's important to go in, and they'll all do the basic workup, right? They'll check a cholesterol panel, they'll check your fasting blood sugar levels, they'll check your hemoglobin A1C, they'll check, your weight and your height and your BMI. They'll look at all of those things and determine whether or not you have an increased risk. And if you're very concerned, if you have a significant family history, say that to them. Tell them what you're concerned about. They're there to help.
But we also don't want to send people down the wrong direction by over to,
Correct.
So I get it. I understand what we're doing. Another question coming in, do hormones play a role in a postmenopausal woman? And if so, will a low-dose HRT patch help?
That is a loaded question, and I wish we had more time. Maybe we should do something on perimenopause. Wink, wink.
The marketing department.
Exactly. So this is such a important topic, especially since HRT has now come out as being much, much safer than we previously thought. So yes, hormones play a role not always in the way that people think. They're thinking estrogen, they're thinking testosterone, they're thinking progesterone, FSH, LH, but there's also hormones that get released by the small intestine, by our visceral adiposity, by our adiposity or fat cells in our periphery that control our weight set point as well, and how well our body burns calories and how well it burns fat. Those include like GLP-1, which is a hormone that gets released by our body, right? AKA Ozempic, right? There's the key word. So the hormones that control our weight are very closely related to the pathways that of estrogen and progesterone and testosterone. We don't know enough information to know exactly what that relationship is yet and how they affect each other, but I do believe it's different in every patient.
Okay.
So will HRT help decrease your risk of cardiovascular complications? We have established that that can be true, but only if you are also addressing the risk and visceral adiposity that accompanies that.
I think you handled that very well.
Sure.
I fully agree with Dr. Lovato here. And certain folks can't take hormone replacement. I mean, if you have a bad family history of breast cancer or ovarian cancer, we have to be careful with you, okay? So it's not, clearly postmenopausal risk factors increase significantly in women. And there's the beginning of the hardening of the arteries and all of that. So it's not a one formula for all. It's just every patient has to be treated differently.
Okay. Yep. And exactly how we started this.
Exactly.
Talking about every patient needs to be treated differently. Another live question coming in. We've talked about fatty liver before. Is fatty liver related to metabolic syndrome?
Absolutely.
Okay. Yeah, you guys.
That's a yes.
Yeah.
Yes.
And in what way, I guess?
Well, your liver is you're eating too much simple carbs, and you are not able to clear at the level of the liver all of the simple carbs. So this is non-alcoholic, what they used to call NASH, non-alcoholic steatohepatitis. Now they call it NASH, metabolically associated.
So fatty liver doesn't necessarily have to do with alcohol.
Fatty liver has to be treated early on. It simply means you have a sweet tooth and you need to stop eating simple carbs. That's the actual treatment of fatty liver, in my opinion.
Let's throw in the alcohol conversation now. Like, where does that impact?
I just said non-alcoholic.
Yes.
Yeah, so it's an alcoholic-induced
different.
cirrhosis, completely
completely
different physiology than metabolic-associated cirrhosis.
Okay.
But
MASH.
metabolic-associated cirrhosis is rapidly becoming the #1 reason for requiring a liver transplant
Okay,
in
wait,
this
say
country.
that one more time. This is important.
So used to be that alcohol-related cirrhosis was the #1 cause for requiring liver transplant in this country. It's now been overtaken by metabolic-associated liver dysfunction from fatty liver disease.
Absolutely.
It's very, very scary
They
and
call
very prominent.
MASH or NASH used to be NASH. Basically, you need to do something about your glycemic index when you have fatty liver. Because if you don't do, it could lead eventually, believe it or not, to non-alcoholic cirrhosis or fibrosis in the liver and all of that. To Dr. Lovato's point, that's actually one of the telltale signs that we're dealing with when someone comes in with elevated liver enzymes and they're borderline elevated. They're not having, anything. They feel great. They have no symptoms. They're beginning. You check their triglyceride. You check their A1C level. They're off. They're borderline off. But I wanna mention here a point about triglyceride. It's we didn't pay too much attention before. Okay, everyone was the bad boy LDL. No, there's another part to the story, the HDL. So we don't have a good drug to raise your good cholesterol, the HDL, high density lipoprotein. It's like a reverse transport of the junk from the walls of the arteries back to your liver. If you have a low HDL, i.e. a high triglyceride and fatty liver, you're a very high risk patient. So we really look at all of this in conjunction together as a whole. The risk factors, is there a family history in folks who had strokes, heart attack below the age of 60, 65, and there is fatty liver, and there is elevated LDL. We then ask for more advanced markers in those patients. Lipoprotein A. This is, you inherit this. And listen to this. Irrespective unrelated to whether you have or you don't have diabetes, whether you exercise or you don't, unrelated to diet. They gave you this, lipoprotein A. You're going to hear a lot about it in the future, LPA. And we don't have yet an FDA-approved drug for that. In simple terms, because I know you're going to ask me, LP(a) is two bad LDL molecule linked together by a disulfide non-covalent bond, which makes the bad cholesterol not only atherogenic, meaning it's going to block the arteries, but also thrombogenic. It's going to make a clot on top of that plaque. That's dangerous. So everyone, and that's a message to the audience, should have in their lifetime, once in a lifetime, a test called lipoprotein A to know their risk factors. We classify those as VHR patient, very high risk patients. In those folks, we're going to be very aggressive lowering their LDL, much more than the general population.
You were talking to me earlier about that inverse reaction between triglycerides and your
good
cholesterol.
right.
Is that true for every single patient, that if their triglycerides are high, they're going to have low good cholesterol?
No, pretty much.
Okay.
We see that.
And again, questions coming in. Thank you guys very much. Great live audience with us. Another question coming in. If your BMI is higher due to muscle mass, could there still be an indication of metabolic syndrome?
Dr. Lovato?
There could, yeah, there absolutely could be. Like I said, not everybody who has obesity is defined as a BMI above 30. Not everybody who has obesity has metabolic syndrome, and vice versa. Right? A lot of it depends on where you store that fat. If it's very visceral around the midsection, then it is a significant risk for metabolic syndrome. BMI is not a perfect way to measure our overall visceral adiposity or any sort of fat percentage in the body, but it's the best we have for now.
What visceral adiposity? Define that for visceral adiposity.
It's your paunch,
Your
right?
paunch.
It's the stuff around your midsection that drives us
size.
crazy.
Okay.
Apple versus pear
versus
type
pear.
of shape, right?
The
If you're an
apples.
apple, you're higher risk than if you are a pear shape.
So it's either here or here.
Okay. Okay. So apple is higher risk than pear. You
Correct.
said. Okay.
Yeah.
That's your body shape.
Not good.
Yeah.
Okay. Back to the muscle mass question. So it doesn't always mean I might be symptomatic for.
Not
okay.
always,
Okay.
but again, I think a lot of folks who might have a higher BMI when they're younger, mostly because it doesn't take into account the amount of muscle mass they have, right? Might get older, start to develop a little bit of a dad gut, it happens, and not realize that increases their risk, despite the fact that their muscle mass is still really, really high. The body composition is the most important thing, not just what your weight is, but how much of that is muscle, how much of that is fat. And it's important to be able to know that, but it's hard to measure.
When I noticed this, here's a question that was pre-submitted. Do I need medication, or can I start managing this with diet and exercise alone?
Diet and exercise.
Start there, always.
Okay.
I never put people on drugs initially. They get a big prescription, say exercise. Defined a minimum of 30 to 45 minutes a day, at the very least 4 to 5 times a week. Okay, and that I would tell you that you want a good 30 minutes of aerobic exercise, targeting your heart rate variability going up and down. With it, at least a good 15 to 20 minutes, to keep it simple, of resistive training, just a little bit to build body mass, muscle mass. And I'm not talking, go be a big buff. No, just to keep muscle tone. But even you can take 10 pounds, do multiple reps, you can build muscle tone. But you need to combine both. And if you're unable, and folks sometimes can barely, just get up, do your walks every day. A good walk, 30 to 40, brisk walk, 45 minutes will go a long way.
I want to add in something. I'm sorry. No, it's
fine.
interrupt
It's
here.
fine. No.
So of course, lifestyle changes, right? We talk about improving our food culture in our home, always some of the first steps that we talk about. It's important for people to realize that if you have metabolic dysfunction and obesity, doing diet and exercise may not necessarily treat your obesity, right? Obesity is a dysfunction of the hormones that control our set point for our weight. But you can improve your metabolic health even if you have obesity, right? I have plenty of patients who are out there and they're going on walks in the morning and they're doing strength training and they're eating the right things, and they might still be at a higher weight than they feel comfortable with or that they want to, but their numbers do improve. And so then there's also medications and surgery, obviously,
the
if you've done all of
GLP-1,
that.
all of that.
So I'm going to ask you about that because on the topic of this, and in the last 2 years, I'm so curious as to hear what you're going to say to this. You could be watching football on Sunday, and every other ad now is GLP-1s.
Yeah,
And
semaglutide and GLP-1.
things you haven't seen a level of that type of mass marketing before. And so are now, instead of someone coming in saying, hey, do I really need medication or can I manage this with diet and exercise alone? They're coming in saying, I just want that medication and I don't want to do anything else.
Yeah. For my patients, when they come in asking for medications, we start with education. Okay, this is what they do. This is how they can help, right? The metabolic dysfunction that occurs within our hormonal system to control our weight and our visceral adiposity. I know you like that term now.
I've learned something.
Is it's affected by so many different things, but GLP-1 has been the game changer in that regard because it's created based in the science of the actual disease process itself. GLP-1 is released by our small intestine and it's supposed to talk to our hypothalamus to control our weight set point. It does a lot of other things though, and there's some really great studies out there that have shown us that GLP-1 and the effect on overall inflammation within the body itself and improvement even for neurodegenerative disorders. I mean, the implications for treatments with this medication are very, very exciting and they're vast. And we're just scratching the surface right now. So as we go along in time, we're going to discover that in my opinion, GLP-1 is one of the most important medication discoveries.
In addition to Dr. Lovat's point, they have a cardioprotective effect. They lower the inflammatory process or the cascade. Think about it. The enemy is at the end of your fork, right? You're taking the carbs. I'm not saying all carbs are bad, but I'm saying you're taking probably the bad carbs. Not you, Eric. I'm talking general. Okay.
You haven't seen me eat yet.
You're fit. You're fit. But the problem is when you have mechanoreceptors in the stomach, and Dr. Lovato, as bariatric surgeon, she would tell you that it sends a signal to the satiety center in the brain that, hey, I'm full, stop eating. Those GLP-1 molecules, those GLP-1 drugs, you know, the Ozempic, the Mounjaro, what have you, all of them, they work by actually decreasing the glucose production in the liver because you just had a load of food, of glucose, and they will increase the insulin production in the pancreas. And third, they would slow the digestive process. So you have stagnation of food right there in the GI tract. Thus, and again, we'll get to the complication or the side effect of these. If they started suddenly at very high doses, you have like a slowing of the peristaltic wave that moves the food all the way to the other end, and people feel bloated, feel like nauseated at high doses if they start very high. That's why it's important to couple that with exercise, with diet, and start them. So what are you doing? You're sending a signal to the brain that, hey, we're full, we don't want to eat. So those folks have no appetite, they don't want to eat, and they start losing weight, and that's the idea. The perfect combo will be to build muscle mass with that. So replace the fat or the visceral fat, the yellowish fat right here, with muscle mass.
So we're going to wrap this conversation up. You guys have been fantastic, but I do want to get to one of these pre-submitted questions that I think is actually a really great question to end on. And I don't think we've really touched on this. Can metabolic syndrome be reversed, or will I always have it?
So my opinion is that just like any other chronic disease, metabolic syndrome, obesity, high blood pressure, diabetes, all of those things, they can go into remission. Will they ever completely go away without treatment? Probably not for most people. And I think that's an important point to talk about when we're talking about treatment for these. And people always ask, am I going to have to stay on this medication for the rest of my life? And I tell them, well, you would never ask that about a blood pressure medication necessarily, right? So if we start really looking at these diseases as chronic as they are, then we realize that there's just a maintenance period that we're going to have to enter into.
I want to compliment the excellent answer you just heard by telling you it depends how motivated that patient is and when did we catch him. When did he present for medical care?
Yes.
How advanced, I mean, don't present to me with an A1C of 12 and call it metabolic syndrome. That's frank brittle diabetes. But truly, when we're talking about metabolic syndrome, fatty liver, central obesity, all of that, high triglyceride, how motivated is that patient to go to the gym, to start watching their diet? Because every time you're taking a meal, you're making a choice. Switch that to legumes, vegetables, the Mediterranean diet, the blue zones, how people live in their 100 years in the Greek Isles, in Sardinia, in the Italian Isles. They are physically active. They have a small patch of garden every day in the Greek islands. That's how they are in the blue zones, because they're eating the Mediterranean diet, which is more rich in legumes, vegetable, fish from the sea. When you're gonna eat everyday carbs, a lot of it, especially at night, what I call the two white ingredients in every household in this country and across the world, the refined sugar and the farina, the flour. Here's with one word, look what I removed: bread, pasta, cakes, cookies.
Everything we love to eat
Especially
at 10 o'clock
at night. Especially at night. You shouldn't do that.
Dr. Khalid, Dr. Lovato, thank you guys so much. Great information, critical information. I want to thank all of you for watching and participating. As a reminder, on the chat screen there, Sarah and Sierra from Banner's team have done a great job with this. There is a Find a Doc link at the top of that chat. That'll help guide you to start your patient journey if you have more questions, follow-ups on everything we've talked about today. And also, as a reminder, this is very important. This will be available to stream and share with those you know will find this information valuable and potentially life-saving, like how we talked about today. So please use the link after the show, share it with family members. Thank you guys again so much for watching, and of course, see you next time.
Thank you, Eric.
Thank you so much.
Thank you.